Hello, I'm Claudia Sweeney, and I will be talking about incidence, an important basic epi concept that we apply when we define a public health problem. When we are interested in improving health at the population level, we start with defining the problem before we move to the other steps. We often define the problem by describing the prevalence, incidence, and burden of disease for a particular condition or health-related behavior or event. As I mentioned, today we will be discussing incidence. So, what do we know about incidence? Well, first, we need to know what it means. Then we should be able to calculate incidence given certain pieces of information. Lastly, we need to think about how we can use incidence data. Incidence is the number of new health-related events in a defined population within a specified period of time, and it may be measured as a frequency count, meaning just the numbers of people or cases, a proportion, or a rate. If somebody already has a condition, such as schizophrenia, or is already engaging a health risk behavior, such as using methamphetamine, they do not present a new case. So they do not contribute to the incidence data for that health-related event. Since they have the condition or behavior already, they are no longer part of the population who could develop the condition or start the behavior. Someone can't be at risk for a health condition if they have it already. Let's have a look at incidence concepts in more detail. Let's first put incidence in perspective using the bathtub analogy. Prevalence is a measure of the occurrence of a health condition, exposure, or other factor related to health. Prevalence only measures the occurrence. We don't know if the condition or exposure or factor is new or if it has been around for a while. Say we're talking about cat use amongst Ethiopian adults over the age of 18, and the time frame is a particular calendar year. The bathtub full of water represents the prevalence of any cat use. In other words, the number of Ethiopian adults who have used cat in the last year. The tap represents the incidence, in other words, new events. As people start using cat and are identified as cases, they are added to the prevalence bath water. Remember that those who were using cat all along are already in the bath. If people die or move out of Ethiopia, they are no longer considered in the prevalence calculation. They can also stop using cat during the following year and thus no longer contribute to the prevalence bathtub. Looking at this image, you can see that prevalence depends on the incidence and on duration of the condition until cessation or death, and sometimes prevalence is affected by migration. Here we have the incidence of two different health-related events, one represented by the blue circles and one represented by a red circle. But we are measuring the incidence of these events over the same time period. How is it possible that we can have three blue circles? Pause the video and think about what these circles could represent. The key question here is, how were the cases defined? In this example, for the incidence of depression, we defined a case or health-related event as an episode of depression, where a person met criteria for major depression. We know that depression is a chronic, relapsing condition for many people, and in between episodes, they don't meet criteria for major depression. There were 3 new episodes in the year for this person, and since we were counting episodes, not lifetime diagnosis or people, we could have 3 new cases in a year. For the study on panic disorder, we used a lifetime diagnosis of panic disorder as the case definition, so this person could only be counted once. In subsequent years, they also wouldn't count as a new case since they had already been diagnosed in their lifetime. We are going to talk about 2 measures of incidence, cumulative incidence and incidence rate. Let's consider the difference between cumulative incidence and incidence rate. Cumulative incidence refers to the number of new health-related events in a certain time within a population. The population measured at the start of the time frame. Incidence rate is the number of new health-related events in a certain time and is affected by the length of time of exposure within a changing population. We call this the person time at risk. More on this concept later. We'll start with cumulative incidence. Cumulative incidence is often the measure we are referring to when we talk about incidence, and it is sometimes called incidence proportion or risk. We calculate cumulative incidence as the number of new health-related events in a certain time frame divided by the population at risk for these events, measured at the start of the time frame. Remember that the event can be a diagnosis of a condition, the development of a health-related behavior, or other event. Cumulative incidence is commonly used. It is generally expressed as the number of people experiencing the condition per population, for example, 100 cases per 1,000 people. Here's an example. Say we are assessing symptoms of anxiety in a population of 300,000 people aged 5 to 85 in Zimbabwe over a 12-month period. We find 24 people with clinically significant symptoms of anxiety as measured by a screening tool. We could say that the cumulative incidence is 24 per 300,000 population during that year. But we would usually use numbers such as 10,000 or 100,000 for the population. So we would say that the cumulative incidence is 8 cases per 100,000 or 0.8 cases per 10,000, although you would normally see incidence expressed as a number greater than 1. Since the incidence is cumulative, you would expect the incidence of a certain condition to be greater if measured over 2 years than over 1 year. It is very important to state the time period clearly. If I have incidence data for symptoms of dementia in a certain population, we can use these data to estimate the possibility or risk that an individual will develop dementia symptoms during a certain time period. Or we can talk about risk at the level of the population and compare risk across cities in different parts of a country, for example. Let's have a look at the cumulative incidence of a diagnosis of major depression as determined by the latest version of the International Classification of Diseases over 1 year in 2 different cities. In Cape Town on the left, there were 50 new cases of depression diagnosed over the year, and in Bulawayo, there were 150 new cases. It could be easy to conclude that there are more new cases of depression in Bulawayo. However, what denominator was used? In other words, how many people were there in the population at risk? Excellent question. In Cape Town, on the left, there were 50 new cases of depression per 10,000 population diagnosed over the year. And in Bulawayo, there were 150 new cases per 100,000 population. So we can say that the incidence of depression over the year in Cape Town was 50 cases per 10,000, or 500 cases per 100,000, and therefore 500 per 10 to the power of 5. And in Bulawayo, the incidence was 15 cases per 10,000, or 150 cases per 100,000, and therefore 150 cases per 10 to the power of 5. By calculating the incidence for the same unit of population, that is 100,000, we have made these two figures easy to compare. Thus, we can see clearly that the incidence of depression was larger in Cape Town than in Bulawayo during the year. There are a couple of problems with using cumulative incidence to measure risk. One issue is under or overestimating risk. When trying to measure incidence in real life, it is not always possible to count the population of interest accurately. Sometimes people who are not part of the population of interest are mistakenly counted as being at risk or the other way around. Those who are part of the population of interest are not included in the calculation. And the size of the part of the population of interest, we can say the population at risk, often changes over time. For example, when we are looking at risk for dementia, we will consider the population of adults over a certain age as being the population at risk. but the death reporting system in the country is particularly slow, so the population at risk is actually quite a bit smaller than we think. Because the denominator is larger than it should be, we will underestimate risk. However, this works the other way around as well. If we are looking at risk for postpartum depression and our denominator is smaller than it should be, in other words, we have identified fewer women as being in the postpartum period than they actually are, then we will overestimate risk. If we only use data from healthcare facilities, we would miss women who did not access healthcare for pregnancy-related care, so our population at risk would not have been counted accurately. When using cumulative incidence, we assume that the population at risk is followed for the whole time period and that all the people we are following are exposed or part of the population of interest over the whole follow-up period. To make sure we know if someone develops a health-related event or condition, we need to follow them up over the whole period and use screening or diagnostic tools to detect new events. This can be very difficult to do, so new events may be missed. Remember that a person who develops the event or condition is no longer part of the denominator or the population at risk, but is now a case. So it's important that we detect this when it happens, as this new person now contributes to the numerator and not the denominator. To show this, let's look at an example of new cases of Alzheimer's disease during a 1-year period. The defined at-risk population are patients over 60 years with diabetes on a health register. If a person was diagnosed with diabetes and added to the register on the 1st of September, they only become at risk from that date. And so their period at risk during the year, which is the study period, is not 1 year but 4 months. The person who was added to the register on the 1st of January was at risk for the full 12 months. This is where the incidence rate comes in. To calculate incidence rate, the number of new cases is still the numerator, but the denominator changes to the total follow-up period for everyone in the study. We call this the person time at risk. Person time is the sum of each person's individual time at risk for the disease or health outcome, from the start of the time period or when they join the study to when they contract the disease, develop the health outcome, die, or until the end of the time period of study. This time can be measured in years, months, or days. Let's look at an example. In this study, we have 5 participants who were followed over 8 years, which is 96 months. Let's look at the person time for each subject. For subject 1, person time stops in year 5 with their death. Their person time is 50 months. Subject 2 is present throughout the whole study. Their person time is 96 months. Subject 3 develops the health outcome in year 3. Their person time is 30 months. Subject 4 migrates away from the area and is lost to follow-up in year 7. Their person time is 85 months. Subject 5 joins the study in year 2 and develops the health outcome in year 5. Their person time is 33 months. To calculate the total person time at risk for the study, we added up all 5 person times, 50 plus 96 plus 30 plus 85 plus 33 equals 294 person months. You can express the same incidence rate using various units of time. For example, 80 new cases per 1,000 person years would be 8 cases per 100 person years, or 0.8 cases per 10 person years. Let's step back again and take a look at cumulative incidence and incidence rate. As I mentioned, cumulative incidence refers to the number of new health-related events in a certain time within a population. The population is measured at the start of the time frame. Incidence rate is the number of new health-related events by the length of time of exposure within a changing population. The strength of cumulative incidence is that it's easy to interpret. But the limitation is that cumulative incidence does not take into account when people are lost to follow-up or when they develop the condition. The strength of incidence rate is that it takes into account when people are lost to follow-up and when they develop the condition. But the limitation is that it is more difficult to interpret, and to collect these data you need rigorous individual follow-up, which is expensive and time-consuming. Let's think about how we can use incidence data. So if we have prevalence data, we can allocate resources now to care for people living with a mental health condition. But what about planning ahead? We know that many mental health conditions become chronic conditions. So if we have an increased incidence, we can predict an increased prevalence in the future. We can use this information to plan services for the future. But given that we are seeing an increased incidence, we would also think about spending more money on prevention to avoid new cases, while still allocating resources to treat the existing cases. Changing incidence can also help to identify conditions needing urgent attention. For example, a rapid increase in incidence of an infectious disease can indicate an epidemic. An increasing incidence of fetal alcohol spectrum disorder in an area can highlight an urgent need to address risky alcohol use amongst the population in general, and in women specifically. In other words, we can see that we need to turn off the tap. In summary, incidence is a measure of the number of new cases of a health-related event over a specified time period. We see incidence expressed as cumulative incidence, proportion, and as incidence rate. Incidence allows us to determine a person's risk of a given health-related event during a given period of time, plan ahead and identify urgent population health needs. Thank you for listening. I hope you have a new case of epi excitement.